Right, welcome to today's Zoom session. It's all about introducing a new pathway for the management of malnutrition in the care home setting. This is a live session which is going to be recorded and will be available to everyone to watch at a later date. Any questions? Chris, if you have any questions, because it's just us and a few others, yeah. I'll just let you ask questions as we go along.
Okay, yeah, no problem.
And we'll go from there. I'm joined by two people, Jacqueline Walker, who's the Tayside Nutrition Network Programme Manager, and Rhonda Manning, who's the lead dietitian of oral nutritional supplements. We were meant to be joined by Maggie Brand, who's the Hair Stain Care Home Manager in Dundee, who's gone through this system. Unfortunately, she can't be with us, but hopefully she'll join us at later training sessions when we go through this at the locality improvement groups when it's rolled out. The plan is that this will start to roll out later this year. So I will now hand you over to Jacqueline and Rhonda, and they will talk you through the whole system.
Okay.
Thank you, Ivan, and thanks to Ivan for having us here today and for you listening. That's brilliant taking part. So you've got Rhonda to start with. So let's send the lead dietitian for ONS for Tayside.
The slides aren't moving on. Chris, I'm just going to get this sorted out. There we go.
Okay, thank you. So what we're going to do today is discuss a little bit about why change is needed. Although we're sort of aware that you will know quite a bit of this, what's been going on in the past, from discussions and meetings that have been taken place with the care inspectorate. We were to have experience feedback from one of the managers, Maggie, that's been described, but she can't be here just now. We're going to discuss how we're going to do this, timescales and contacts. Okay, so as you possibly know, undernutrition is a big problem in care homes, and just generally within the general public it is an issue, but for care homes we're looking at 40% of residents versus 4% in the general public. So the reason that we're needing to make change, because at the moment what we're looking at is in the region of £320,000 is money spent in Tayside just on nutritional supplements in care homes, and we know that there's roughly about 800 of care homes that one sort of within the between 16 and 17 who are actually on supplements, and we know from work that we've been doing that quite a lot of these are no longer appropriate, and quite often there's been people maybe on them for a number of years on the wrong one and no longer needing it. We have come across within some of our work some patients, for example, who have like a BMI, there's one at the moment we have picked up with a BMI of 50, who has been putting on lots of weight because she has been on supplement inappropriately for a number of years. So, and we'll just generally know that the system that we're using at the moment needs improved governance, and the GPs are involved quite in a way sort of inappropriately, so we're wanting to look at how we can change that so we can remove the need for the GP's involvement. And also we are aware that there is quite a bit of waste around ONS, and again you'll know that yourself from the number of the way the current system works. Because they're patient specific, there's a huge number have to be thrown out. And also from this piece of work will also help to meet the care inspectorate standards.
On the waste bit, I think that's our biggest waste is ONS products now. We've cut down a lot of medication in care homes, but I think the ONS waste is something that we're all aware of and that we would all wish to see come down quite considerably.
Thanks, Ivan. So again, this would be something that I'm sure you're familiar with, just who is actually at risk of malnutrition. And there's various reasons for it, and obviously just even things like sore mouth, even just not sitting up properly in the chair can have quite a big impact. And I'd say one that people tend to forget about is even just your bowels. Like that can have quite a big impact on what you can actually eat. And another one, I suppose, is just general pain. So if somebody even has a full food, for example, then that can knock their appetite, because just generally it makes them feel quite rubbish and put them off eating. So again, you would tend to think about what physically around the mouth pain, but just pain anywhere, for example, can make it more difficult. And again, this will be something that I know that a lot of people will be aware of now, is just obviously to be undernourished isn't good, and there is more risk of infection, fatigue, even wound healing, for example, just takes that bit longer. And I think just generally sort of how these people feel about themselves, if you are undernourished and thin, just generally does it affect your mood. Okay. So just to give you a little bit of an idea, again, this won't be new to you as to what's actually happening at the moment. So the current way that the model that we're using is that you will be approaching the GP if you feel that somebody is losing weight, or the dietitian. You will the GP writes a GP10 script, and then you're provided with the supplement.
Yeah, that's what happens.
So that's just pretty much, shouldn't be new to any of you. And this is what we're hoping to move forward to, this new model. So we're going to discuss this in much more detail, but obviously this is what we're looking at, is that as you identify the malnutrition risk, again, as you're doing at the moment, that we'll be asking you to record that onto an Excel spreadsheet, which will be returned to the Department of Nutrition and Dietetics, and we will organise the order for you for the supplements required, which will then be delivered straight to the care home. And again, it will be hopefully such that the way that it's written into the system, that it will be appropriate prescribing. Okay, so I'll pass you over to Jacqueline.
So I'm going to speak on behalf of Maggie Brand, and unfortunately I'll never do as good a job as Maggie. So please bear with me, everybody who's listening. These are Maggie's slides, and I hope I can capture in the slides what Maggie really feels about the test that she's been the test in the new pathway since she started it last year. So Maggie has a care home in Dundee. You may well know it. It's the Hairstains care home. And we asked her to pilot the new pathway about probably September, October time last year. November, it says here. She really feels that it has been successful, and I think we need to thank Maggie and our whole team in terms of what they've done to try and make this work, and to be that early adopter, which always comes with it lots of issues when you're starting things, because, well, we don't always get things right, and so there's a bit of co-production in terms and co-design in terms of how things, when you run into problems, how you then solve them. So it's been great working with Maggie and her team. But she really feels it's been successful, and that the home itself has reaped the benefits of this new way of working. And in that, she speaks about that there's definitely been an enhanced clinical monitoring of the people that she cares for in Hairstains around about their nutrition and their dietetic needs. So she feels that is an absolute positive. And I know from the work that I'm doing with the Care Inspectorate and Jacqueline Dennis, who's our nutrition lead at the Care Inspectorate, she definitely sees the benefit of this system in terms of meeting the client's nutrition and dietetic needs. She also feels that there's been no delay in obtaining supplies, so that maybe makes you think that there might have been issues in the past with the current way of working. But in terms of obtaining the oral nutritional supplements, that has been achieved smoothly and met her needs. The other thing from Maggie is that she has felt that clients that once they're on ONS, because of the system recording their weight every month and their MUST score every month, we're able to identify if people are beginning to lose weight quite quickly. So that increased level of attention to monitoring their weight and their intake and their appetite, they're able to then adjust for that and make changes to help people meet their clinical outcome and as quickly as possible. Next slide. She's also felt it's very the benefit of working closer with dietitians. So that's a real benefit as well, that the dietitians are very much part of that support in the care home to meet the needs of the nutritional needs of the care home population. She has felt that it's been easy to input the data into the Excel spreadsheet. So that is good, because there has been some, when we've looked at it, we've thought, gosh, this seems quite big, but actually she's found it quite easy. So I hope everybody else finds that. I'm going to speak about the monitoring forum a little bit later, so I'll speak about that in a little bit more detail then. Knowledge, she feels that the clients are actually getting better using the ONS, because again, that's seen by the monitoring form. You can see that their weight's increasing and that they're actually making a difference. And I think that's something that she feels really important, that it is actually working, and that that it encourages the staff and the patients, or the residents, should I say, to consume ONS in different ways, to stop that fatigue that people can get by having the same, ready-made milkshake style ONS every day. Because we're using a powdered ONS as first line, and we've given the care home recipes about how they can use that to freeze it into ice creams, to add it to their porridge or their custards, to make up various different milkshakes with it, to have it hot, to have it cold. So to add fruit juice, to add Coca-Cola, all these different types of things you can do with the powdered milkshakes. And that's helped as I said, this sort of fatigue that clients can get using the same product.
Robin, who did the previous, was saying that Iron Brew and the shakes work lovely.
It does. It becomes a bit like a soda, with ice cream soda, and so things like that all help. And the most important thing about ONS is it has to go down the patient's throat to get benefit. So anyways, and the staff at Hairstein have been really good at making sure that they provide ONS in quite innovative ways. And that whole concert support from the dietitians as well. She's also felt that it can help her identify when things aren't going so well. So through monitoring, she can identify triggers where weight loss is occurring, and then they can try and sort out the issues. What she was alluding to there was an issue where through the monitoring form, that they could see that patients over a month, everybody was beginning to lose weight on this form, and they thought, oh, what's going on? And then they realised that there had been a change in the catering staff. And so some of the procedures, needed to be looked at and built in. So that's really been quite useful. And this is, obviously, I've said it as well earlier, that it leads to clients being treated faster. So we're not starting from a very low starting point, which, somebody losing a lot of weight, we're saying it's harder to get the weight back on. It almost acts like an early warning system, so you can get early intervention and much faster recovery.
So from that, then I get the feeling that everyone is put onto the spreadsheet.
Yes.
All of that is then sent off to yourselves, the dietitians. You review that, and then you can get back to the home the next day or something and say, we've noticed that you've got 3 residents who look as though they're starting to lose a bit of weight. Can we look at their care plan? Can you look at that? Others, they seem to be increasing. Can we now change that?
Exactly.
So you're the ones who are looking and providing that skilled guidance to care homes. Because I think one of the things from a lot of care homes' point of view is that staff regularly weigh people and they write down the weight, and then nothing is done because they've written it down.
Yes.
And they think that's it. And they've not done that bit about, oh, they've lost weight since last time, we need to flag that up with someone. Until, say, the manager reviews it or there's a review. I think a lot of homes, they record it, but don't do anything with it.
Right.
So at this time, they're still doing the recording, and the people who are doing the reviewing of that are the dietitians, who are the skilled people to do it, and they can assist the care home to work with that. Is that?
That's right. That's it. I mean, in this home, they've been doing that review, and they're actually monitoring it as well as that. So it's almost like double monitoring. Yes. But what you're also getting is that governance of the dietitian, who's the right clinician at the right time, monitoring that the patient's needs. The monitoring form is for patients who have a must of 2 or more. So it's not for everyone to be on the monitoring form. But saying that, there might be a case that in the future, if this is successful, to look at, say, right, well, what are your needs around this regards to electronic monitoring?
Not everyone's going on the spreadsheet.
Only those that are identified with a must of 2 or more.
Okay, yeah, I misunderstood that. I thought it was going to be everybody.
Okay, but we can speak about that and see if that's something that potentially could be added in. Okay. Logistically, I think Maggie's felt that it was very smooth, the training, the delivery, and it was easy to use, and that she's found that it's space friendly, because that's one of the other things. I think there can be a lot of different types of stock using the current system, where we've managed to condense it into 1 or 2 maybe key ONS items, so it saves space. And that she's felt that she's had fantastic support. Well, that's Rhonda's team, so well done, Rhonda. Okay. So let me take you on now to my part of the presentation, which was around about how this is actually going to work. So as and we've alluded to, there is an ordering plan or monitoring form. So what will happen is that each care home will be provided with the dates of when the deliveries will be given right throughout the year, because we will have planned that in from our logistics side. So you'll know when you get your ONS delivery, and that will come once a month. 2 weeks before that order is due, though, we need some actions for the care home. And that is that we would, number one, the nutrition and dietetic ONS care home admin person will email key personnel, and we have to identify within each home who that key personnel are, the Excel ONS monitoring form. There will be a return date when that is very clear on the form, when you need to send that back to us, and you need to tick that you've read it, so we know that you've actually got the email, because we can't have it that this form sits and then it's not been actioned. The care home then would complete it, and that, as I said, is for patients who have a must of 2 or more, so that's those patients that are most at risk. There might be some that with a must of 1, which maybe, you know, you've tried things and we've agreed that they should be put on the form, or that we're stepping them down. They were must of 2 and they're now improving and they're now must of 1, but we want to keep an eye on just that everything's going in the right direction. So mostly it'll be must of 2, but there might be the odd patients that are on for other reasons as well, for short term. So that would be completed and that would be returned to us by the agreed date. I must emphasise at this stage that if we don't get that form returned, we cannot process the order. So your ONS is going to be compromised if homes do not complete the form. You have to complete the form so we can look at the governance, as we've already alluded to, and that we can review that, we can be in touch with the home if there are any issues, and we then would create the order based on the information of that month's return from that home. The Nutrition and Dietetic Services ONS care home admin will acknowledge the receipt of the form, and then they action the dietetic service, the dietitians and the dietetic support workers that we have within this team to actually review the form, and that may be followed up either with email correspondence or with a telephone, or it might actually involve a face-to-face visit with the dietitian to just check on some key vulnerable people.
Okay, if a care home doesn't send it in by the date you want, is there a system where you will chase them up?
Yes.
Or are you relying on them just to do that themselves?
No, we will chase them up, but we have 104 care homes to manage. So an admin role, we don't want to be chasing up. And I'm sure that it'll finally get into this is just the way of things and the way of working. So we do probably expect a little bit of chasing up initially, but we're hoping that people will actually do it and just get into this as the way of working.
I think if it makes it easier for care homes, I think a lot of them will just come naturally. Because if you're not waiting for stuff and it's not going through GPs, if this is a simpler system, then I think you'll start to see that work.
So the next step in this is that the Nutrition and Dietetic Service may alter what you require. Because you may say, well, we expect that we need X for this patient. They may review it, they may then have a discussion with you and decide, actually, we need to change it. This patient doesn't need it anymore, or let's try a different product, or, you know, let's increase it, or recipes. and therefore they might change the order. So they would let you know if there was going to be a change, and also if there was going to be a change in that person's diet regime, any changes that they need to go home to make.
So the changes are done by the dietitian, not by the care home? No,
they'll be done by the dietitian, and then you could make that change. And they'll be reviewing it the following month to see how that change is going. Okay. They would then create the order, and the order would be put through, and we would then deliver it to the care home. I think what we will have is a receipt of goods as well. We probably need to do some kind of receipting of goods, but I'm sure you're used to doing all that, where it's signed off so that the driver, you know, when you get it, the driver
we get that for continence products and stuff like that. That's not unusual.
Great.
We're open 24/7, so there's always someone who can sign for something.
We will probably be having the logistics team and the drivers coming round just to check access and how to get in over the next few weeks to make sure that the access and things.
I suppose, the continence lorries can do it.
Yes.
And the bin lorries and all that. So it shouldn't be a difficulty at all, really.
But why don't we use the continence lorry then?
What was that, Chris?
Why don't we use the continence lorry?
Well, I think they looked into that, but there were problems.
Yeah, I think it's a private company, the continence lorry, and so we couldn't get our stock onto that. It's a slightly different supply route for continence. But I think what we're looking for is that this would be one of maybe a few items. So it starts with the ONS, but it might build. Yeah. So we are going to try and make best use of the lorry and make sure we can pack it, really, by the end of the year.
I think also that the continence lorries must start very full.
Yes, probably do start very full. Okay, this isn't a very good slide, but it's just to give you a screenshot of what some of the monitoring order form will look like. This will have patient details on it, and it will be, you wouldn't be expecting the patient details to be updated every month. That'll be copied across, and you might have to add some new people on, but not so that we are going to try and save time by sending you a new order form each month, taking the information from the previous month. This form also will calculate for you the BMI. It will calculate must, and it is very easy to complete with drop-down boxes, so you can keep it hopefully as tight as possible.
So we would put everyone onto that, and then it would indicate who was a must of 2, and we would then send that form off to you, and then you would do the monitoring of the people who were 2 and 1. So we would use that form for everyone.
Potentially.
And then we could monitor and send that to you, and then you would see who the 2s were. So we don't have to do the working out.
You don't have to do the working out. You don't have to do the working out. It will do that for you. At the moment, we're only interested in those patients of must of 2. I suppose we need to have maybe that discussion about whether everybody could go on it if a home wanted to do it, and then we would highlight the ones that are must of 2, and where you would refer those patients that are must of 2 to us to identify them. But one of the issues that we have found is that staff can have difficulty doing the percentage weight loss, working out BMI when it's, weight over height squared. And
so Robin was going through that with us on the other form, and talking about, if someone's got a full leg amputation, or if they've got ascites, or they've got edema, and even my head was beginning to whir at the amount of mathematics. But she made it simple, and it's there, but it's not the easiest for everyone.
So this form and the work that you just spoke that Robin did on Monday in terms of the must go hand in hand, really. So it definitely need to have all the staff that are involved in face-to-face working out of must to have watched Robin's video on Monday. Okay, 5 steps to getting this into your care home. First of all, we will, as in the Nutrition and Dietetic Service, will write to every care home when there's due start dates. Will be a letter that will come out to say, we're going to be starting this in your care home round about this time, or round at this start date. And they will then arrange with the home when to go in and ensure that they've got all the information that they need. And they can make sure that the care homes themselves have to make sure that the staff are trained using Ivan's must training and the food first one. Ivan's having a little bit of a problem getting the food first one up and running on YouTube, but that's in hand. If we have to do it again, I've said we'll do it again. So it would be up to the care homes to make sure that the appropriate staff are trained. The dietitians will come in and they will review all the residents on ONS to make sure, as Rhonda had said, that it's appropriate, they're on the right one. There's no point starting the system with the wrong people on it and on the wrong supplement. So that will happen. And they will also provide all the documentation. They will create that monitoring form with all the patients' names and things on it initially, and they will stock the care home with the ONS that they need. We're asking care homes to obviously use up the ONS that they have, so that again we don't have waste, which might mean in the first couple of months it's not really a full proper order.
If care homes have got a resident who's on ONS which is named,
yes,
and that resident is no longer using that ONS, what do we do with that named ONS?
You would still have to throw it out.
Yeah,
we would still
it
throw
was
that away.
dispensed under GP.
Okay, it's just that bit about that stock, carrying stock over. You can only carry the stock over
if it's for the patient that it was designed
yes,
for.
so that's right. That's to throw that. Just to clarify that bit.
Yeah, sorry.
No, that's fine. It's just so that that's what we would look at. And, I mean, we may sit in the back of the office taking all the names off, but that's not something we're allowed to do. So we would have to get rid of that.
Yeah, have to get rid of that. But so use up the stock. At that time as well, the dietitian will write to all the GPs cancelling future ONS. So that will stop. The GP ONS will stop. And you will then move over to the new order model, and all your ONS will come through this model.
Okay, that seems fair enough.
Timescales, we're carrying out the reviews currently, so the dietitians have maybe been in or spoken to some of the care homes in Tayside already. I think you're quite far through that, Rhonda, and your team. We're beginning the training now, as you can see, and this is part of the training. And we're really looking to have our first delivery of the new model going out probably into some care homes in Dundee at the end of July, which means we need to start the new model with some of these care homes at the end of June. We've got dates set up in Angus for the 28th of August for the northwest region.
That's for Forfar and Kirry, and then it'll move from there to Brechin and Montrose about 2 months later, once we've got that bedded down. So before the end of the year, most of Angus will be onto this system.
That's what we're hoping. Yeah, that's what we're hoping. That's what we're aiming for. We're obviously monitoring change constantly. As I said, I think earlier on, it's very difficult sometimes to get all of this in terms of new systems absolutely 100% right at the beginning. We're expecting some bedding down. We can only change things if we know about it. So please work with us. We want to co-produce it. This whole model was co-produced right at the beginning with care home staff, and we want to keep on that sort of co-production. And we probably will have an event sometime next year where we go back and look at how well it's doing, what can we do differently, and co-assess how it's getting on.
Yep.
If you have any issues, here's details for myself and for Rhonda. And we both contacted it within at NHS Tayside, and there's number and email there. Further information on the formulary that we use is available here as well. Very happy, Rhonda, myself, and probably Ivan, to answer any questions that you might have.
I think that seems fairly reasonable to me. Anybody, Chris?
No, just everything. It's not just powder available, is it? There are other things.
There are other things. So the formulary that the dietitians work to is quite extensive. What's available to GPs is actually quite limited. So that's part of I think the very good part of this model, where dietitians, rather than other healthcare professionals who don't have at their fingertips all the available ONS to meet that individual's nutritional needs, it will be the dietitians who will be doing that, who have the full extent and range of prescribing abilities. So yes, there will be some other items.
Yeah, there will be other, but we would be hoping that the majority will be a powder. Is the aim.
And if I misunderstood, but it looks like if, say, we decide that somebody needs to be on this system, and by the time we've done the form and everything, it could be kind of 6 weeks before they get anything.
No, you would get it all within the month. So if it's so the email would go out to you 2 weeks before the delivery date. So you would be updating that form on a monthly basis. If somebody new came in If they were coming in from a hospital, they should have their ONS with them for at least 2 weeks. And we can probably look at what can we do in the interim. You know, what can we do? So again, it's that link to dietetics, and we can talk you through whether you need to have an urgent supply that we can send out to you, or whether we can cope with, maybe you've got some of that supply already in the home, and we can top you up.
Because it's not named, you can then use that.
You can use it.
And so you've got say 15 bottles of something, and you say you've got 15 bottles of that. Use that, and we will get you a supply of that by the end of the week, so you'll be fine. You can use what you've got because it's not named.
Yes, exactly.
Okay,
that's right.
But you need to phone up the dietitian to talk to them about that.
Talk to them about that. Yeah, that's right.
So in theory, we can run a stock then?
You can what?
Run a stock.
You could run out of stock. I would hope
could we not run out of stock? Would we kind of have a stock? That's what I meant.
All right, yeah.
Yes, you probably have a stock. I mean, from a good procurement perspective, we should be running with no stock, you know, but in reality, that's what happens.
Yeah.
And it does also mean that if you have someone that is, that you have a must of 2 and you have referred them to dietitian, you could actually start them on the powdered ONS to see how they get on before the monitoring form. So you can actually do some early interventions rather than waiting. You can actually start with a first line, which would be the powdered ONS.
Okay. Does that make sense, Chris?
Yeah, that's fine,
Yeah. And then I suppose if someone then becomes off the powder ONS, you just keep that, and you've always got that as your first line if you need it, and for anyone else. And you'll know how much roughly, not to the, in mil, but you'll know roughly how much stock the places should have.
Yes.
When
The monitoring
it comes to filling in the form.
Sorry, Christopher.
When it does come to filling in the form, I think it would be easier if we put all the residents on it, because if we didn't, we would have to work out the must score before we put them onto the form, which kind of defeats the object of the form.
Yes, I'm with you on that, Chris. I think I'm going to put everyone on it and just send it off to Ron, and they can sift through it. Because I think from our point of view, it makes it seem for the care inspector and everyone, you are monitoring and we're doing all of that. And we're not missing anyone. No one's slipping through a net from our point of view.
I think that's probably quite reassuring for us. And this is part of the sort of co-design of this, is that we don't want to put too much work on you. We need to put the work that we absolutely need, so we felt that it was appropriate.
Well, we actually do all this work already, so the form would actually be saving us work.
Yes, I think it would be as well. If we put everyone on, and it does all of the working out and everything. That just means that's a joy.
That's a joy. Good. That's great. That's good. What the form will also do is that you are asked to kind of complete information about the stock, so that we don't have you overstocked.
Okay.
So there is information about the stock, and then the tool, the form is quite clever. It'll calculate out how much stock you need based on the outcomes of it'll do that for you.
Yes.
So it is quite clever. I'm hoping it's not too clever, and it does actually work. It does work, but if we need to change the form, we have the ability to do that. I'm also looking at develop a sort of technology-enabled care solution for this, a sort of digital, not just an Excel form, but actual digital solution for this that would make it much slicker. But it's always better to test a system using something like this first, and then the developers can develop something. So I've got funding in to develop a new system, which would be quite slick.
Okay. Anything else, Chris?
No, that's it.
Okay then. Well, I shall end this. As said, have you got any other things you want to say?
No, again, just to say thank you very much.
No, that's okay.
Thank you for everybody that's listening. Thank you, Christopher, for your questions.
Thank you.
I'll see you soon, Chris.
Thank
Thank
you.
you. Bye.
Bye.
This is a stop.